This is Walter Kemp. This is Ischemic Heart Disease Part 2. As I said, there'll be 5 total lectures regarding ischemic heart disease. This is just a sunset, I believe, just along the freeway in Montana. So there are ischemic heart disease 2. Once again, websites Dr. Hughes and I have for questions regarding USMLE, Twitter. Like I said, hopefully we'll be starting that again very soon. Like I said, forensic pathologist, very strong interest in general organ pathology. I really enjoy the heart. I really enjoy teaching medical students. I remember one of my internal medicine residents told me he was a jack of all trade, master of none. It's kind of the way I look at myself. I hope forensics is my master, but the rest of it I just kind of know the basics of, which I think is good for teaching students, I hope. So here are my disclaimers. Please pause, review these, make sure they do not apply to you. I want to teach people pathology, but I want to make sure that people are viewing the lectures are supposed to be. So if they do not, if it's not appropriate for you, please stop watching. Third disclaimer is there, same thing. And then below that is basically how I teach and stuff like that if you want to watch the presentation. There are my references. So we'll start out each lecture again with a question. So I'm going to pause, go through it, see if you can answer it. The idea with this is that usually that people don't have the material and are reviewing it. That makes you pay attention to certain areas of the lectures you go and get more out of it. It is shown to increase retention time or retention of the material. So causes of cardiac ischemia. Last time we talked about just ischemia in general. So we're talking about specific causes. Obviously, the main cause of cardiac ischemia is atherosclerotic disease, coronary artery atherosclerosis. Like I said, I think it's always funny that coronary artery atherosclerosis is also called coronary artery disease, which would imply it's the only disease of the coronary, but there are other diseases of the coronary. They're just so uncommon that coronary disease is synonymous with atherosclerosis. But I thought it was kind of interesting when they talk about the idea of a fixed versus variable. So an atherosclerotic plaque produces a fixed amount, unless there's an acute change in it. But if there's a stable plaque, it produces a fixed degree. But on top of that, you can have some variable, as we talked about before, with things like whether the person is more vasoconstricted or more vasodilated, whether it's producing more nitric oxide or more endothelium can affect that. And so you could have somebody who could be symptomatic in one time and not symptomatic with the same degree of fixed plaque because of that variable contribution. I just thought that's kind of a really cool contribution to it. So to the right of it is basically talks about resistance. The most important thing to understand there is the vessel radius. So as the radius decreases, that's going to greatly increase the resistance. And that's very important when you talk about atherosclerosis. As far as memorizing the rest of it, please don't. I don't think it's absolutely necessary. I remember we had to learn calculus for pre-med. I haven't used any since then. Some basic math, but the idea that as you decrease the radius, you greatly increase the resistance to the flow of blood. Okay, so critical narrowing for the coronary artery, basically it's around the 70-75%. So what that means is once the coronary artery the plaque reaches 70 or 75% stenosis, it means that that's the point at which the person will become symptomatic. The reason being is that to that point, they can get enough blood through the point of stenosis to supply the heart with the oxygen that it needs, albeit with extreme circumstances. For example, incredibly marked physical exertion or things like that might go beyond that, but otherwise they can. So at 77% they can't. And so when they're exerting themselves, now they have increased demand in the myocardium because of the exertion, but they cannot get enough blood flow by the point of stenosis to reach that demand. So they reach that imbalance in supply and demand. But once they stop, then they go back, then the chest pain would go away. And it says once you reach about 90% stenosis, that even at resting, they can't get around it. Now, the thing that affects this stuff, though, is that the idea of collateral circulation and that you can develop basically collateral flow around. So you could have somebody who's at 90% stenosis who doesn't have potential chest pain at rest. And then to the right of it, this is a vessel that's narrowed by about 70%. And so that would be that thing. So that's a kind of an important number to know because that's it. Okay, so the other important is the importance of endothelial cell dysfunction. Endothelial cell dysfunction what leads to atherosclerosis. I mean, that's the start of it. But also that can contribute to that variable degree. So you could have endothelial cells putting out too much endothelium or something like that and causing vasoconstriction. And also if it's disrupted, it's not able to perform its normal antithrombotic functions. And so thrombosis can obviously contribute to an acute event and things like that with a person with coronary atherosclerosis. So there are other reasons why people can have cardiac ischemia. It's not just coronary artery atherosclerosis. These are just some. Vasculitis is possible to get vasculitis of the coronary arteries. Kawasaki's is well known for that. Other ones can potentially. Embolism, paradoxical embolism through a patent foraminal valley. Coronary artery aneurysm, once again with Kawasaki's. Vasospasm, which I think is becoming more and more. When I was in medical school, we learned that it was relatively benign, caused atypical chest pain and that, but it actually is showing to be, I think, more significant and can actually cause ischemia and infarction. Dissection, you get coronary dissection, congenital anomalies. What I showed to the right of it, basically this is where you have anomalous origin of the left coronary artery from the right sinus of Valsalva, and it has a high osteal origin of the right coronary artery. So the arrow at the left is the anomalous origin of the left coronary artery. It's basically arising right above the commissure, and the arrow to the right shows the high osteal origin of the right coronary artery. So they have both been associated with potentially sudden death, although the most common association, best associated with sudden death, would be when you have the right from the left, not from the left from the right, but they are all both. So, okay, and I mentioned before the concept of collateral vessels. The idea that if atherosclerotic plaque develops slowly, you can actually have blood flow around it potentially. And I think this is something true. When you think about, the body is pretty good at dealing with stuff when it develops over time. For example, if you have 200 or 300 milliliters, 400 milliliters of blood in the pericardial sac acutely, that's a significant amount and can cause cardiac tamponade. But I've heard in books and stuff like that, they've reported up to 2 liters of fluid in the pericardial sac that accumulated slowly. So when things happen slowly, the body tends to be better able to adapt to it, which would make sense. And I think atherosclerosis would be one of those. If atherosclerotic plaque develops relatively slowly, the body can figure out some way around it to get blood flow around it. So here, the question is, what's the cause of the cardiac ischemia? So the black arrows show the distribution of the left anterior descending. The white shows the circumflex, and the red shows the right coronary artery. You can see there is yellow discoloration in the subendocardial region in all areas. There's also green. That's actually, the individual was jaundiced, and actually in an area where you have dead tissue, you can get a deposition of bilirubin, and that's kind of interesting. So I've seen green strokes and I've seen green infarcts. But it's all circumferential, so why would that be? And then I'll pause. So hypotension. So with hypotension, you'll get generalized decreased flow through all the coronary arteries, and that's how you could have something circumferential. Otherwise, when you have ischemic injury, it should fit in the distribution of the coronary artery that led to it. So angina is one where Robbins really deals with clinical symptoms. There's not very many times where Robbins deals as much, I think, to me, with clinical symptoms, but this is one, so that's why I'm covering it for sure. So angina, the important thing is to distinguish angina versus other causes. This is where Dr. Stern's book is really good. That symptom to diagnosis goes through a lot of really good stuff in there. But anginal pain, or that related to ischemic heart disease, is usually described as a pressure, a tightness, a burning, or a heaviness. So you have sharp pain, that's usually not angina. It does not vary with respiration. That was considered more pleuritic. It's usually steady and lasts for a few minutes, most often less than 5 to 10 minutes. And then they have talked about the Levine sign, or somebody will clench their hand over their sternum. It's usually diffuse and not localized. It's usually retrosternal, behind the sternum, or left precordium. And it can be anywhere. It can radiate arms, jaw, always important. You see associated features with it: tachycardia, diaphoresis, nausea. They can also have fatigue and weakness. And then it's precipitated usually by something, or can be precipitated by something. So physical exertion is a really important one. Emotional factors. Cold, potentially. Cold causes potential vasoconstriction, which can lead to the ability to cause angina. And then it's usually relieved by rest or by nitroglycerin. Nitroglycerin causes dilation, or rest, it just goes back down to where the supply and demand equalize again, and you don't have the ischemia causing the angina. Okay? So the symptoms that are associated with it, I've kind of made this to kind of show kind of the pathophysiology of it. So you can have you have a decreased systolic function. If you have ischemia of the left ventricle, it's not functioning the way it should be, which can cause a dyskinetic apical impulse, the heart not kind of contracting the way it should be because it has decreased function. You have decreased diastolic compliance, which will lead to an S4. When the blood gets squirted in there, it doesn't move as well. It'll cause that S4. Decreased systolic function and diastolic compliance lead to rowels, so buildup of fluid in the lungs. You can get papillary muscle dysfunction because of the ischemia, at least of the papillary muscle. That can lead to mitral regurgitation, so you can get acute murmur because of that. And then increased sympathetic tone will lead to diaphoresis, increased heart rate, and blood pressure. This is my mom's cat, Sylvester. Sylvester was actually, I think, abandoned, and then came up, and Mom adopted the kitty cat, and has a vet in town who just really likes helping with these cats and stuff like that. So Sylvester's done pretty good since then. So different forms of angina. You can have stable angina, unstable angina. So stable angina is stable. It means the person has chest pain associated with the typical amount of exertion. So like they'll climb up 4 flights of stairs and they'll get chest pain. Climb up 4 flights of stairs, they'll get the chest pain. The symptoms stay stable, whereas unstable, it changes. So they say, a week ago I could climb 4 flights of stairs before I got chest pain. Now I climb 1 flight of stairs to get chest pain. That's unstable. And so stable angina, what you have is you have a blockage of the coronary artery a blockage of the coronary artery by atherosclerotic plaque that is basically not changed. It's not changed. It's grown to the point where it's causing symptoms, but there's no really acute change in it. Obviously, that variable component that you can get from the vasoconstriction or from local mediators causing changes in the vessel can change a little bit, but for the most part, it's not. And then with stable angina and unstable angina, you have ischemia, but you have no infarction, so you don't have dead tissue, so you don't have release of mediators. And then clinically, though, like I said, this is where that kind of fixed threshold, the plaque, and then the variable threshold come in. So you can have some variation around that as to when they're going to have chest pain and how much chest pain and stuff like that. So to the right of it, the black circle shows the outer aspect of the intima. Now there is some red at the arrow. That's just some neovascularization. That's not an acute change in anything like this. So this plaque is very stable, but it's at a point, probably 70-75%, where it's going to cause ischemic injury or ischemia, and that would be the stable angina. Unstable angina is where you have a change in the symptoms. So if I said, for example, they said I used to climb 4 flights of stairs a week ago before I got chest pain. Now I'm climbing 1. And so what that's saying is that there's some type of change in the plaque. So they've gone from 70 to 90% or something like that. Or they have some prominent component of vasoconstriction. Normally I walk up the 4 flights of these stairs. This time I decided to run up them or something like that, something very different and things. But once again, it's ischemia, but no infarction. So there's no increase in heart muscle enzymes or anything like that you can test for. So both these two come with the idea that, it's a change in the plaque in unstable angina. So it kind of goes along with a stable angina, goes along with a stable plaque, and unstable angina goes along with an unstable plaque. There's a change in it. This just kind of shows both of them in a way. So to the left of it, you can see there's a cross-section of coronary artery with a real significant degree of stenosis. You can see the lumen that's left there, so that would probably be causing stable angina by itself. And to the right of it, there's atherosclerosis, and there's actually thrombosis. So this person had at least an acute change in the plaque, and then thrombosis. So there's a pretty good chance this person is going to have an acute myocardial infarct. And if I'm looking at them, they probably had an acute myocardial infarct and sudden death. But you can see to the left, that's stable. To the right of it, that's an acutely changed plaque. Here are 2 more. To the top left of it, so I've indicated where the lumen is. There's a non-occlusive thrombus. It looks collapsed. It looks like it's all pretty much occlusive. There's a little slit there, but that's just the artifact of the histology. And then the plaque, you can see the left. And then to the right of it, there's an occlusive thrombus, and you can see where the wall of the lumen should be. So these are both acute changes. One's non-occlusive, one's an occlusive thrombus. 2 other types of angina that will occur is variant angina. This is one that's been associated in the past with, it's probably still with Vasoconstriction, it's also been called Prinzmetal's angina. This is one I said in medical school we learned was completely benign, but it's actually apparently not necessarily completely benign. They usually have a non-significantly stenotic atherosclerotic plaque if they do have any, and then they can have profound vasoconstriction. You can imagine if somebody had a 50% plaque and the coronary artery just absolutely clamped down, they could still become obstructed because of that. And then silent ischemia is another one you'll hear. Silent ischemia basically means that they're having injury, ischemic injury to the heart, but they don't feel it. I remember when I was in medical school, somebody told me they've lost 95% of their heart and they haven't felt anything, and they were a diabetic. So this is commonly in people who have diabetes, also in people more elderly, and also in women as well too, are known for having silent ischemia, where they have injury to the heart, but they actually do not feel it. So I just kind of made this up. This is going from, I believe, from Dr. Stern's book, but I'm not 100% certain on that. But angina, you'll have non-pleuritic, meaning doesn't vary with respiration. Substernal pressure occurs usually on exertion and improves with rest. That's kind of typical for angina. For what would be related to ischemic injury to the heart. You can have acute onset, less than 7 days, or subacute if it's greater than 7 days. In that case, they probably want to do a stress test, look to see, and it's probably going to be stable angina. If it's less than 7 days, then you're obviously going to look and see. You want to do EKG and troponin. If the troponin I is elevated and the EKG changes are there, then you have a myocardial infarct. If there are no EKG changes, no troponin I elevation, it's unstable angina. But the dotted line is very important. With unstable angina, you still have an acute change in the plaque. And that acute change can change and worsen, and therefore unstable angina can go on to myocardial infarct. So the one thing you don't want to do is miss somebody who's in unstable angina and allow them to progress to acute myocardial infarct. So that's why when you hear the term acute coronary syndromes, which would include the non-STM elevation myocardial infarct and ST elevation myocardial infarct, they also include in that unstable angina. And the reason is because it's acute. Something is going on in the coronary. It's undergoing a change. It's causing ischemia, but not yet infarction, but that could progress. So unstable angina can easily lead to a myocardial infarct. It's just at the time it isn't. So mechanism of acute coronary syndrome, common one would be thrombosis. But you can also have potentially just hemorrhage in the plaque. But the most common will be a plaque rupture. It releases the contents of the core, which are very thrombogenic, and then those will cause thrombosis and then blockage of the coronary artery. When you have thrombosis, different things can occur. You can actually completely lyse it. It is possible for somebody to develop a thrombus and lyse it on their own, or it can be incorporated into the plaque itself. If you have partial occlusion, that could lead to unstable angina because you're still going from, say, 50 to 70%. You're still having a change and increase. Or it could lead to a non-ST elevation myocardial infarct, where only the subendocardial, which remember is the most at-risk region of the heart for injury. And then with complete occlusion, will oftentimes cause an ST elevation myocardial infarct. Non-ST elevation myocardial infarcts in the past have been associated with subendocardial and complete occlusion with ST elevation transmural. So to the right of it, this is an individual who actually had a thrombus, most likely, that resolved relatively, became an organized thrombus. You can see there the black arrow, and then you can see the residual lumen there. So the resolution of this was that it became it's scarred basically, and that didn't clear out. Okay, so I'll pause and then go on. Okay, so 51-year-old male presents with a physician complaining of new onset chest pain. He does not smoke and has no history of diabetes mellitus or hyperlipidemia. Of the following, what features of the symptom would be typical for angina? And so the answer would be that pain occurs behind his chest, radiates left upper extremity, with inspiration but no expiration. It doesn't vary with inspiration. Usually does not last a few seconds. It's not sharp. It does not occur only at rest, usually with exertion or something like that. And so the best one would be that. So then use reflection, look back, think of what are 5 things I have hopefully taught during the lecture. It's the 5 things you learned from it. And this is a good way to kind of cement the material. And then here, this is flying out of Billings. This is in the western side of the Rimrocks, which is around where I live. You look down, this is actually Reberg Ranch area. It's an area by the airport and that. So I hope this lecture has been useful for you, and thank you.